Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens, and in this week's episode, we're going to spend some time talking about burnout. We're going to spend some time talking about technological tools that are billed as helping with burnout, and we're going to spend some time talking about what burnout actually means in the medical setting. So this is going to be a good one. I'm really excited about this. So a couple of weeks ago, there was an article in Fortune magazine about using AI tools to avoid provider burnout. And I liked this article for a couple of reasons. I thought that it was interesting that it first started by setting a really beautiful stage for primary care physicians and other primary care providers, nurse practitioners, et cetera, really improving patient outcomes. So they spoke about the overall cost savings of seeking care from your primary care provider or your PCP, as opposed to going to the emergency room or an ambulance ride to a specialist. If you have a primary care provider, your care is much more cost effective, and often you have a better experience than you do when you go to the ED. They mentioned that 30% of Americans don't have a PCP. Which is due at least in part to a shortage of providers. Interestingly, they did not touch on many of the other reasons why one might not have a PCP, including being uninsured or underinsured, having problems maintaining a relationship with a PCP due to, a provider, due to, how do I want to say this, right? Perhaps my own personal bias is coming into play here, right? Perhaps you've established a relationship with a PCP as part of a large medical organization, and then perhaps they moved 45 minutes away, which makes them not a very convenient PCP. Anyway, there are a lot of really interesting health equity related reasons why one might not have a PCP, but for the purposes of this article, they focused on the shortage of PCP providers. So they mentioned that if you, the patient, regularly see your primary care provider, you are 19% less likely to die prematurely, which sounds great, right? Follows really logically that the more we can reduce the tasks that our primary care providers are doing that are not patient care, the more patients they will be able to see, and therefore the more people can get these great benefits of having a primary care provider, which is great. And then they went on to talk about, how AI tools such as documentation support can help with some of that. And as I was reading through this article and I kept seeing references to provider burnout, I started to think about a concept that I ran across a while ago and had kind of bookmarked for more reading and more discussion. And that was that the concept of burnout in the medical field is less what we think of when we think of burnout, right? When I think of burnout, just be completely honest, I'm a working parent of two children who they were in kindergarten and preschool during the pandemic. That's what I think about when I think about burnout. When I think about burnout in the medical field, when I think about the symptoms that our providers are experiencing, when I think about the feelings that their work elicits, that doesn't quite equate for me. So I found this really lovely paper on burnout and moral injury. And the concept of moral injury is one that I've been chewing on for a little while. And I really think it's interesting. So let's turn our attention to the concept of moral injury for a second. Moral injury as a concept has been floating around since the Vietnam War. When we had military personnel return from Vietnam, they were dealing not only with post-traumatic stress disorder from the threats to their mortality, right? They were in grave physical danger, losing life or limb. They were also experiencing symptoms of post-traumatic stress disorder from injuries to their morality, from being ordered to carry out actions which conflicted with their own personal, ethical or moral codes. And so the concept of moral injury first started to float around as we were discussing the Vietnam War. It first linked to the medical community in an editorial for Stat Magazine back in 2018, and the authors of that article have continued to develop this thought. I just have to quote from the article, which is, of course, cited in my in the notes for this. IT investments in healthcare have, instead of efficiency, delivered a triple blow. They have diverted capital resources that might have been used to hire additional caregivers. They have diverted the time and attention of those already engaged in patient care, and they have done little to improve patient outcomes. So hi, it's me. I'm the problem. It's me. So as we're thinking about technological solutions To reduce burnout, we need to admit that part of the reason why our providers are experiencing burnout or moral injury is the fact that we have invested heavily in IT solutions that have not solved their problems, right? They have added more factors for your average caregiver to consider when they are trying to balance their ethical burdens, right? A caregiver in a patient encounter really, truly should have one priority: the patient, what's best for the patient. Instead, the caregiver in any actual medical encounter in the United States is thinking not only about the patient, but how do I document what's appropriate in the EMR so that we can hit our coding requirements, so that we can get reimbursed, so that my practice can continue to stay afloat, so that we are compliant with all of our regulations. You see how this is stacking up, right? We are diverting a lot of attention and a lot of prioritization from the patient. So, as we are thinking about AI tools and IT tools to help with provider burnout, we first need to first, we need to admit that we're part of the problem. Second, we need to ensure that the new tech does not compound the problem. And then three, we have to ensure that the new tech does not introduce new problems into the ecosystem as well. So, if I'm using an AI tool that's supposed to reduce my provider burnout, I need to think not only about the operational load, right? So, does this actually save them time? Is it efficient? But also, is it reliable? Is it equitable? Is it contributing to better patient outcomes? Or is it freeing up time and effort that will allow my provider to do the things that will contribute to better patient outcomes? So, these are the things that we need to be considering when we're evaluating new AI tech and new technical tools for our clinical ecosystems. It's really important as we're thinking about this. And I keep beating this drum about how do we evaluate these tools? What do we need to think about when we're bringing new IT tools into healthcare? We need to make sure that IT and clinicians are making decisions together, right? I'm involved in a bunch of different projects about technical solutions that are supposed to be improving providers' lives in their course of work. And I cannot do that effectively if I don't have a chance to talk to my clinicians and, best case scenario, get a chance to shadow with them and see the actual problems that they're dealing with. When you're doing pilots, or if you're thinking about how to evaluate a vendor, make sure that you're measuring clinician satisfaction, both self-reported and looking at some downstream measures of that. Do the docs like the tool? Do the nurses like it? Does it work for everybody's workflows? And then more than anything, you also have to consider, you got to keep the patients front and center. If this doesn't serve the patients, then it's not going to be a good fit for your practice, no matter what its benefits might be.